folks. It's just a tad after 1 here. I think we'll get started to our bi-corona webinar series. Today, Barry Glassman, Dr. Barry Glassman is going to be speaking on the myths associated with OSA, oral appliance therapy. And I'm really looking forward to hearing him doing his thing. I'd like to start off by thanking and acknowledging all our sponsors, not only for supporting our programs, but for what they do for the industry. You know, for us to do the best job we can for our patients, we need good appliances, good tools of the trades that are advancing all the time. And these folks are doing that for us. They keep up in the game based on our feedback to them. So I just want to shout out to them and give them a thank you for all of their efforts and their aid in helping to further this field. Bi-corona webinar series. We have a few more coming up. Today's the first one. April 21st, does medicine have it covered with PAP? Why physicians need dentists? And this is Dr. John Remmers that are going to be speaking on this subject. I'm really looking forward to that. The fully digital workflow for dental sleep medicine, Dr. Suresh Sharkande, Friday, May the 1st. Always a pleasure listening to Suresh. And of course, we have Don Malizia, the master of dental sleep medicine literature, speaking to us on anterior midpoint scooting stops that mess up your TMJ. Why bother anyway? I'm really looking forward to this talk. This is a topic that's near and dear to me, and I've learned all about this concept from both Barry and Don over the years. And I think there's too many people that are, you know, just missing out on helping their patients with this concept. So this afternoon, we have our dental sleep medicine speakeasy, couple-hour session. You can step in, step out anytime. It's an online meeting room. Our discussion this afternoon is going to be predicting oral appliance therapy success. So hopefully you can join in there. If you haven't before, this will be our second session this afternoon. And a join link can be found on the homepage of our stdacademy.com. A little bit of housekeeping. There's an option for audio, computer audio or phone call. Pick which one you want to use. Then you can submit questions as an attendee. And you can actually make this little panel disappear by pressing the little red or arrow you see up there. And you can raise your hand if you want to get the attention of one of the panelists, and they'll reach out to you. Okay? And CE certificates will be emailed within 72 hours of today's session. Just make sure you answer the couple questions at the end of the program in order to qualify for the CE. So myths associated with OSA oral appliance therapy, Dr. Barry Glassman. Barry doesn't need any introduction, I'm sure, so I'm going to forego that. But I'm really excited to be associated with him and teach with him, and I'm looking forward to what he's going to share with us this afternoon. Take it away, Barry.
Thanks, John. There's so much going on, obviously, with the pandemic and virus, and actually, Greg Vogel isn't the only one. Several others have contacted me and said, would you cover your recommendations for how we handle and where we go in this environment? And the answer is absolutely not, because my opinions aren't any more valuable than any of yours. And sometimes when I'm listening to some of the opinions of some of the people who are speaking, I think the same. So this is all new territory, and our goal here was to really get to some science and to issues and to some myths that are unrelated to the current environment, to make us think better, to make us think more thoroughly, to help improve some of our treatment and diagnostic concepts. So that being said, why are there myths at all? Why do we have them? And why are there so many of them? And the reality is that we all know we entered this field at various times in our careers, from some of us in the late 90s to those in the early 2000s and later. And we entered this field with some as dentists, and we entered this field. And what we did know is that we were entering what was already a broken field. As John Remmers will always say, we've got this strange specialty with essentially one diagnosis and one treatment, which obviously he knows better than anyone isn't exactly true, but that concept. And there were many things broken about the system to begin with. Add to that all of the incredible myths that we've learned that we as dentists have brought to the table, and now we take all these dental myths and we try to take this round hole of dentistry and put it into the square hole of medicine with our myths with us. And so there's an awful lot of logic in the absence of science, and we're used to going and listening to things that make sense to us, and then accepting that as real and applying it, and often seeing some level of success, whatever it may be, and then through confirmation bias, accepting those as real. The reality is, if we look at the science, it not only helps us better in our treatment, it takes some of the responsibility that we assume of this perfection of getting everyone better to some level based on an AHI. It takes some of that responsibility and puts it in another cart. It puts it in a more reality, sense of reality. I know when I started, if I had a patient with an AHI of 15 and then I did 2 weeks of therapy and I took an HST and then found out that now the patient has an AHI of 18, I would literally panic. I said, what the hell just happened? This is supposed to help people. Hopefully that answer and several others will get answered in this short hour. I also have had some responses laughing at the fact that I can't believe you're doing a webinar and you think that you're going to cover myths in an hour. That in your normal lecture would be on, you now be on slide 2. And I appreciate that. And I'm concerned about that because we have 10 that I would like to get to. And the reality is if you know, I understand people come and go on these things all the time. I often get on these webinars with full intention of watching and can't stand it and leave after 10 minutes. So I understand that may be the case for even, you know, no matter who's speaking. So I hope that's not the case and that you find it enjoyable. And at the same time, if it goes a little bit longer, John, so be it. And if need be, we've talked about putting the rest of the myths somewhere where we can come back and gather and over this virtual world and see if we can make it happen. So that being said, let's go to, if I could do this. John, you want to go to the first slide for me? If mine's not popping up here. There it is. Okay, so although physicians are well trained, they are not well trained and thus resistant when it comes to developing a relationship with a dentist or even considering oral appliance therapy. So I'm suggesting this is a myth. And for a statement to be accurate, the whole thing's got to be accurate. So although physicians are well trained, they're resistant because they're not well trained when it comes to oral appliance therapy. I question the first portion of that sentence, although physicians are well trained. We make this assumption that they're well trained, but they're well trained in what was already a broken system. Keep in mind that, for example, and we'll get to this as we go, that for a long time, severity of obstructive sleep apnea was based upon AHI. We'll show you the science and the problems with that alone. Our really sharp physicians get that now. The vast majority of them don't. And so either they don't get it or they don't want to get it because they want to, in some cases, use the lack of total resolution in terms of AHI of oral appliance therapy as a way to suggest that therefore oral appliance isn't successful, and therefore you need to leave the oral appliance because it didn't work for you. The term work for you is very distressing to me. Even when I hear Fauci talking about will Plaquenil work when you add it to Z-Pak, or will the vaccine work? So does the vaccine for flu work? Does it work? Well, when you look at the number of people that get the flu in spite of the vaccine and the number of people who die with the flu in spite of the vaccine, and now I ask you the next question, does the vaccine work? So the problem isn't that it isn't in the medication specifically. What in this instance, the problem's in the concept if it works. If a patient says to you, this is very interesting, Dr. Barry. You're going to make me an oral appliance. Will it work? What's the answer? So you have a patient. Let's go there. You've got a patient who's got an AHI of 15, and they're non-obese, and they're 15 AHI, and it's 14 on their back, and they're relatively young, and they've got no significant comorbidities, and they've got snoring. I mean, you're sitting there smiling because we know there's a really good chance that there are many factors that suggest that this patient is going to respond well. And now the patient says to you, let me ask you this, Dr. Barry, will this appliance work? If anyone would suggest that the answer would be most likely or yes, we've got a problem. Because what we've just done is we've taken responsibility for that which we can't control. We can certainly say there are many factors that make me smile. There are many factors that make me think there's a really good chance. And with your effort and my effort, I truly believe there's a good opportunity to help you significantly. And I can only tell you this, if you were my brother and I liked you, this is the appliance, this is the treatment I would do for you. So let's not assume, therefore, that physicians are all well trained. And many times when you go to develop relationships with physicians, I found when I worked with dental sleep masters, when I was working with so many dentists trying to get them to get relationships with physicians, the number one problem that we faced was that myth that these physicians are so well trained, and I'm not a sleep doc. I don't know as much as they know, so consequently, I'm nervous to meet them. What if I become exposed for my lack of knowledge? And the answer is, you're not a sleep doc, and you don't have to know what they know. You have to know what you know, and you have to know it well. And you have to know what is myth and what is real, because if you bring the dental myth to the physicians, they'll know it. They'll know it. So know your science, but you don't have to be trained to the level they are. The other issue here, of course, is the relationships where physicians are with sleep appliances. And here's the good news. People like our early work with Keith Thornton and the early work with SomnoMed and all of the current companies, they are all doing ProSom. All of them are doing tremendous amount of work to increase the footprint of oral appliance therapy in the minds of our physicians. They have laid the groundwork for us. It is so much easier to develop a really positive relationship. But I'm not saying it's easy. It's easier than it was back when we started in the late 1990s. So that becomes very, very important, that you know what you know what you don't know, and don't pretend to know what you don't know when you're dealing with physicians. You just be honest. Just be honest. And we're going to talk about other concepts when it comes to physicians next. So there's our first myth. John, I'm looking to change this, and it's not. There you go. Thank you. Okay. So John, you want to take this? John, can you hear me?
Yes, Barry, how you did? I just unmuted myself. We've launched a poll here. Can everybody see a poll? Can you see Barry on your screen? Launch poll. So launch poll.
It just says, yeah, there
we go. Okay. I'll let you take it from here, Barry.
Okay, so it says the McAvoy study is excellent to demonstrate that oral appliance therapy is as effective as CPAP for mean disease alleviation. In 2016, McAvoy wrote a study, and it was fascinating. This and other studies were actually supported by ResMed, which drove us crazy, Don and I, when we looked at this. The McAvoy study suggested that when they looked at their sample, when they were done, that patients that were quote unquote compliant by definition with CPAP therapy did not reduce their potential for cardiovascular accidents. And therefore, since they didn't reduce it, and we do have some studies that suggest that oral appliance does reduce it, therefore we can use the McAvoy study as excellent to demonstrate that oral appliance therapy, when we're speaking to physicians, is effective as CPAP for mean disease alleviation. You need to now select one of the following: yes or no. John, are you unmuted? Because you need to take it from here. I'm not sure what.
No, I'm good here. I'm just trying to get my cursor back so I can close the poll. But
should I hit submit?
Yeah, go ahead. But you have to answer it first, though.
Oh. It's not letting me.
Okay, so we've got 80% yes and 20% no. There we go.
Great. Okay.
So the poll's now closed.
Okay, great. Can we go to the next slide?
Yeah.
Okay, so let's look carefully at this McAvoy study. The McAvoy study was done on Asians that were non-obese and, most importantly, had no significant report of sleepiness or hypersomnolence. So as soon as you look at that sample, and what's more is what the study suggested is that all of the patients demonstrated the use of the CPAP 3.3 hours, or maybe 3.3 hours a night or less. Now, in defense of the study, what they said was, well, that's the average use. So there is reality as opposed to academic success. This is in fact reality. But when you look at the sample of non-obese, and most importantly, what we're learning is that there is a significant, really significant degree of change of response and to patients who are hypersomnolent or not. So those patients who have OSAS, oral obstructive sleep apnea syndrome, as opposed to simply obstructive sleep apnea, will respond differently and have more potential comorbidities with in therapy and then those that don't. So the study really has some holes in it. And more than that, you can imagine what the physician's response to this. They were essentially being told that it doesn't matter, that their patients on CPAP were not gaining an advantage. I don't think it's exactly what the message you want to bring to a physician when you meet with them. Keep in mind, whenever we meet with physicians, what we have learned is that if we want to develop a relationship with a physician, our job isn't to tell them how good our treatment can be for their patients. Sorry, it just isn't. Our job is to let them know how in some way we can help them. How can we help them? And whether the most common response to that is, well, I can help when you're frustrated or patients are frustrated with CPAP. We have an alternative that can help them. And then when we're done, they can see you for their follow-up and their additional studies and remain under your care. And while we're doing that, we're going to make sure that you are well informed with each step of the process. Wow, now you can help me. That's great. What a great team we would be to help close the loops to all the patients who, in some way, shape, or form, have maybe less than ideal CPAP usage. Again, great verbiage. How can we help them? So, when I say the best relationship to develop, best way to develop a relationship with a physician's office is to make headway with the front office and schedule a lunch and learn with the staff and the doctor. I don't know what your experience is, but I will tell you mine and the experience we had with literally hundreds of dentists that I've worked with. And the answer is, it wasn't a lunch and learn that made it work. It wasn't that you brought them candy or you brought them things that technicians bring them, or that pill salesmen or pharmacotherapy salesmen bring them. That's not who we are. The biggest mistake, in my personal opinion, that was made by the American Academy of Dental Sleep Medicine is when they put dentists and made us become durable medical equipment suppliers, DMEs. That put us as a DME, to someone who supplies a CPAP. That took away any concept of our contributing medically to that patient's care. That's Da Vinci. So, sorry about that. I don't have children, but so that is so. Yes, there are people have told me that they've had success with their lunches and learns, but I find not in general. I don't think that's the best way. The best way is to gain respect for your physician, and our approach has always been the following when we're trying to develop this relationship. That myth that they're going to appreciate us because oral appliance therapy is better and we have to show them that is in fact a myth. The truth is, what we have to do is gain their respect, and then we gain their respect by being honest, and by good reporting, and by treating and helping their patients, or treating and not helping their patients. The first few letters I would write to physicians, I was so proud because I could write back and say, look how well this patient's doing. And then a patient came along and didn't do well with oral appliance therapy, couldn't wear their appliance. And I thought to myself, oh my God, now he's going to use this against me to prove that oral appliances don't work. Okay. And the answer is, if we've established the relationship, just like he sends you patients that admits that CPAP don't work, we can send him back patients and be honest and tell him that oral appliances don't work. Myth number 3. Screening should be done on the basis of a clinical exam or a history of hypersomnolence. Epworth, spelled wrong with 2 P's, sorry, is a good screening tool. Imagine should be imaging, and pharyngometry are good screening tools. Okay. Everybody taking a deep breath. I said the word pharyngometry, just saying. Okay. So, what happened? John didn't like the pharyngometry, so he put it back.
I'm trying to protect you, Barry.
Screening should be done on the basis of a clinical exam. So how many times have we heard this? You gotta do an exam. You gotta look in, and you gotta see the mound patty, and you gotta see the large tongue, and you gotta see the retrognathia, or you gotta see all that, and all of that, as far as I'm concerned, is noteworthy. It's noteworthy. But Strauss, for example, in 2008, made it clear that there are no parameters, no single parameter, or combination of awake parameters that can predict oral appliance or obstructive sleep apnea. It can't happen. So all of that's kind of fascinating, but it doesn't mean anything. You may want to make the assumption, and you might, and there's some good literature to suggest that scalp tongue may be related to sleep apnea as a result of a parafunction that occurs. I got it. Makes sense. But it's not clear, and there's no direct relationship. If you're thinking that there's a direct relationship between any 2 factors in medicine, chances are you're wrong. So, but Barry, wouldn't you look at a large tongue and decide whether or not that patient should be screened further? I said, no, I wouldn't. I would use a validated screening tool to make the decision as to whether or not that patient is likely to have a sleep disturbed breathing condition, and then talk to them about appropriate testing to make that determination. So would I look and see? No, I wouldn't. I would suggest that in a dental office, we screen everybody and then use that. Why would I use something that has no direct relationship? Why would I do that? Now, children are different. And I'm going to hold off the discussion of children because it gets involved in the interest of time. Hopefully, maybe we can get to that. But children are different. When I see wear patterns in children and small arches and whatnot, that's a whole different ballgame. Those are the kinds of things, wear patterns in children on small arches, that make me start asking the parent, does Johnny snore? That makes perfect sense to me. Just remember, children should not snore. Snoring is not normal. So consequently, that exam might lead to those questions more than in an adult. What about Epworth? Well, there is no direct relationship between sleepiness and the likelihood of obstructive sleep apnea. Kwan in 2013 wrote about the abuse of the Epworth sleepiness scale. Epworth was originally created in a hospital in Melbourne, Florida. No, sorry, Melbourne, Australia. That's Freudian. In Melbourne, Australia, to identify narcolepsy. Nothing to do with sleep apnea. And yes, some of our patients are sleepy, but think about this. Think about how we just talked about a few minutes ago, how we took patients with OSA, obstructive sleep apnea syndrome, and patients with obstructive sleep apnea and separated them. There's large numbers of patients in each of those categories. And so there's many patients with significant sleep apnea with no hypersomnolence. And more importantly, there are many things that cause hypersomnolence that are not related to sleep apnea. Marriage. Well, I'm just saying, can make it difficult to fall asleep. Anxiety, idiopathic insomnia. There's all kinds of other issues that make sleep difficult. So to assume that because you don't get quality sleep, you can have periodic leg movements with pathological periodic leg movements with significant arousals that alter sleep architecture and cause sleep fragmentation and may in fact affect your quality of sleep and thus lead to hypersomnolence in the absence of obstructive disorders. So so Epworth is not a good screening tool. We need to take an Epworth on every patient that's diagnosed positively. Once they've been identified as possible, then we go ahead and take an Epworth. Then why? Because insurance companies want them, because physicians want them. That makes sense. Imaging and pharyngometry are good screening tools. And we know full well that narrow airways can remain patent and wide airways can collapse. So while size of the airway is in fact a potential factor, that's what it is, a contributing factor, but it's not a direct factor. And there are other contributing factors that can outweigh simply the size of the airway. Interestingly enough, Strauss in 2008 wrote talked specifically about pharyngometry, and he talked specifically about imaging and saying that there was no relationship. In 2012, he wrote another article about CBCT, and he talked about 3D and how in their evaluation with very, very complex mathematics, he could not make a direct relationship, but he saw in the future, combined with one or two other variables, that it could become a screening tool. I've said that for a long time. I've even said that, John, about pharyngometry, that if pharyngometry does in fact give us an accurate measurement of the airway, if you then combine that with other factors, it might prove to be a screening tool once you come up with that algorithm. Think about it. Adjusted neck circumference happens to be one of my favorite validation tools. And what does it use? It uses circumference. The neck circumference wide is related specifically to central adiposity, the weight. And so we know weight being the number one risk factor. Therefore, in Fleming's and Remmer's adjusted neck circumference, the neck circumference plays a major contributing role in deciding whether or not that patient's going to be positive or negative. So you have a 17.5-inch neck in a male. That patient's literally very close, if not already, at the level of suspected apnea. So doesn't it make sense, therefore, if we could look at the airway, and it was related, but the algorithm has yet to be determined and created. I made that suggestion to the people who work with the pharyngometry. They never did any further research or any work to create that algorithm. Remember, when we're talking about imaging or we're talking about pharyngometry, we are talking about measurement of the specific measurement of the size of the airway and the potential role that it could play. They are mowing my lawn. Can you hear that? No? I hope not. Okay. Let's go next, John. There's a poll question, I believe, coming up, right?
I think so, as soon as I find my cursor again. Okay. Okay, so there's a poll here. Let's see.
Thanks for participating, guys. It's kind of fun, guys and gals.
Okay, there you go.
Okay. We are taught AHI reduction to 5 and many to 10 is successful. Therefore, if we reduce a patient with an AHI of 29 to 17, we can state categorically that this is not successful treatment. You have to select yes or no. We got it all? Everybody got it?
Well, 20% voted. It's going up exponentially. It's going faster and faster.
This is what happens when people vote. That's amazing. Remember, we're not looking at your vote. You're the only one who knows.
I can see it. No, I'm just joking.
So, before we go on, let's talk about this. Let's say I have a UCA, a female. It's a true story. This actually happened in our office. So we've got a female, age 71, who has an AHI. In this case, it wasn't 29. It was 17 to start with. All right? Bear with me. Female comes to your office, AHI 17. One of the first questions we tend to ask patients is, so, Mrs. Jones, tell me, what started the ball rolling? Why did you go and get tested in the first place? She was referred by a physician for oral appliance therapy, by a sleep doctor in our hospital system. So now she says, oh, well, I have headaches every morning. And where are they? They're anterior temporal and posterior cervical. Gotcha. Okay. And she went through all kinds of therapy. She saw the neurologist. He couldn't help. Just said, take over-the-counter medication. Saw the general physicians. He couldn't help. And finally, said, well, why don't you go get a sleep study? And went and got the sleep study. And in the sleep study, she had an AHI of 17. She had time below zero, but below 90% at zero. The average event was 15 to 20 seconds. And nevertheless, she had what was being considered mild to moderate obstructive sleep apnea and referred to us for oral appliance therapy. She's 71 years old. She's lean. She does not have upper airway resistance syndrome. She doesn't know whether she snores because her cat won't tell her, and she sleeps long. And when we do the examination, we find that she's got worn teeth, extremely worn, and it looks like a right excursion is very common. Right canine's worn, after if she's aware of any tenderness of grinding clench her teeth, the answer was no. And when we do our palpation or exam, we find that there are some positive spots in what we call the bloom, the deep cervical areas when we do the palpation. So we sit and talk to her. And the long and short story is that we wound up making her an anterior midpoint stop appliance that eliminated her headaches. So now she's got no headaches, which was her chief complaint to begin with. And she's got an AHI of 17. Let's submit this. John, you want to submit it? And then go to
Well, I just want to say there's 78% voted. So those of you that haven't clicked on yes or no yet, I'm going to give you 4 seconds. 4, 3, 2, 1. Okay, the poll is closed. And what we see here is 23% yes, 77% no.
That it, and oh, I'm what was the question?
The question was, we are taught AHI reduction to 5, many accept 10 to be, you know, the rule, right?
Treatment went from 29 to 17.
29 to 17 is not successful treatment. 23%
okay.
Yes, 77% no.
And I'm going to say it was a totally unfair question. And the reason it was unfair is, one, you didn't have all my answer to that question would have been unable to answer because I don't have all that information. So I want to make, this is really important. We got to get past the concept that an AHI is the answer to our treatment. We're falling into the trap of our physicians, and we have to train ourselves and teach them, if that's at all possible, that that's not our goal. There are many people. We know the work. Got it. We know the work that was done by Levy. And Levy pointed out that for patients above the age of 50, the likelihood of altering their comorbidities with successful treatment of their obstructive sleep apnea goes down significantly. Now, be careful with this. I am not suggesting, John, can you go back to the slide? I'm not suggesting.
Which slide do you want?
That the question slide.
I don't think I can anymore.
I'm not.
Oh, the question?
Well,
are you on number 4 now?
Yes.
Okay. You're on number 4. That's what we should be on.
So the point is that there are many patients, first of all, that have AHI. Think about this. Just think about this. What's below 5 is normal. That means, by definition, by Dement, and when they all got together and they made the decision that an AHI of 5 was going to be normal, that it was totally acceptable for patients to stop breathing 5 times a night. Is it totally acceptable for a patient to stop breathing 5 times an hour a night, 5 times an hour a night, if that stoppage of breathing is a minute and a half and the nadir gets down to 68? Is that acceptable? Of course not. But what's their AHI? It's 5. So would I treat that patient? This is not a common scenario, but would I treat that patient hypothetically? The answer is, of course I would. John, can we get out of this somehow?
Well, are you not on?
I'm still seeing the quick results of the quick pull.
Okay, so let me get my cursor back here and hide the results. Okay.
Okay.
And
thank you.
Is that right?
That's good.
Okay.
Thank you.
Okay.
So I'm not suggesting, would you suggest therefore that patient should be treated? The answer is, of course he should be. And there's a patient at 17 that would have never been diagnosed. She's got no comorbidities. The likelihood of changing the comorbidities at 71 is minimal anyway. She's got an AHI of 17, but there are minor events. The likelihood of endothelial dysfunction or the kinds of comorbidities or hypercholesterolemia is gone. It hasn't happened. And what are we concerned about? So, you would think I would have been concerned when I picked up the phone and called Joe Schellenberg, Don, and called my sleep doc that sent this patient. And I said, hey, Joe, let me tell you the story. And, yes, with the proper relationship, Schellenberg turns to me and says, that is brilliant. Absolutely. Now, Are you always going to get that response? No. Do you need to develop that relationship with a physician? Yeah, absolutely. But please, we need to understand that AHI simply tells us how often an event occurs. It says nothing about the intensity of the event. It says nothing about the duration of the event. And therefore is problematic when we try to discuss that relationship to mean disease alleviation. Why do you think it is that in some cases you are extremely successful with patients with severe obstructive sleep apnea and not successful with patients with moderate obstructive sleep apnea? The reason is it's multifactorial. There are reasons, but one of the reasons is that AHI alone is totally the wrong determinant to use. So yes, if you look at statistics and you look at wide numbers, we are more likely to be successful with mild and moderate cases. No question. When you look at it has nothing to do with that patient that is sitting across the table from you. Excellent. Let's go to the next one. How are we doing with time? Oh, okay. Oral appliance therapy can cause severe TMD issues. I'm going to just be brief here. I don't want to tell you that I don't know where, I know exactly where this comes from. This comes from the fact that we are not well trained as dentists, and it's not our fault, but we're not trained in joint dysfunction and joint pain. And when you think about it, what is it that scares us most? What scares us most is that which we don't understand. You can stub your toe in the morning. It can hurt like hell, but you're not worried about it because you know just what you did. And yet, it's not a problem. We have friends, when you're my age, that have small areas of problem. They want to go and they do exploratory, and they close the person up and say, you have 6 months, get your life in order. There's no direct relationship between the amount of pain and the seriousness of the disorder. So when a patient comes back after they've been in an oral appliance and they're in excessive pain for some reason and in the joint, it scares us. We think that maybe we've done something wrong because it's so much of an area that we don't understand, and we've been informed how serious TMD can be. Most of the discomfort by far in the joint is a result of sprain or strain. And the sprain or strain is not created by holding the jaw forward. We're not putting any strain on any musculature, or essentially we are extending the ligaments, the medial collateral ligament and the retrodiscal lamina slightly when we hold it forward. But it's a combination of taking that joint out of its safe harbor and then parafunctioning and then putting a strain on the joint. Oftentimes, that can be altered by altering the force vectors by adjusting the appliance without retreating it back if you don't want to. If you're in the process and the first thought is, I got to bring this back, you may not have to. You may not have to. Think about altering wherever the contact takes place. Remember the report, the work of Hattori, who pointed out that the further anterior the contact, the less forces on the joint. So look and see where those forces are. If you're hitting way hard on the right side in the posterior, there's a good chance you're going to get some damage in the left joint. Absolutely. Alter that. Take the contact away. Don will cover, when he talks about anterior midpoint stops, why it's our preference in terms of ease of adjustments and ease of insertions, as well as decreased likelihood of causing joint problems. But all I'm saying is that if you ask a guy like John Viviano, who is a true master at oral appliance therapy, and yet will tell you, I'm not a master in joint therapy, but interestingly enough, he does just fine. So somewhere along the line, the organizations that treat joints decided that if we tell everybody, or may believe this, that we're the people that should be doing this because we're the ones who know joints. I don't think that for a second. I don't think they're the people necessarily who should be doing it because they know joints. They may be the people who should be doing it because they're used to treating people with chronic pain and they're used to treating people without a cookbook answer. But many of them have developed a cookbook answer to treat their chronic pain, so they're the wrong ones to treat it anyway. What I'm saying to you is if you're treating oral appliance, doing oral appliance therapy to treat sleep, for me, the key is not to be afraid of the joint. The key is to understand that the number one factor in your success with your patient is your relationship with them, not the appliance you chose, not the design, not how far, not your bite registration, your relationship with your patient. It's everyone with COVID-19 is now very excited because we're going to move to telemedicine. We're going to do insertions with telemedicine. I'm going to do follow-ups with telemedicine. And my heart is breaking. My heart is breaking. If that's the future of dentistry, if that's the future of medicine, I'm kind of glad I'm 71, 73. No, that's not where I want to be. I want to see that the eyes of my patient. I want to be able to touch their shoulder. I want to be able to hear them. I don't even, frankly, this is really hard for me teaching under this. This is real. I don't see you. I can't see whether you hear. I don't know what you're doing. I don't see if you understand anything I'm saying, which I can when we're all together, assembled together. This is my least favorite mode, and it's probably why I can't be you. I can't sit there and listen to someone. I also get frustrated by the myths that they teach. That's also part of it. Let's move on. Dental changes must be prevented. If significant changes occur, the appliance wear should stop, which is really fascinating. So we've all been there. We all know, and it's frightening. You spend your entire career learning that our goal is to create perfect occlusions, and now we're going to put in oral appliances that are going to screw them up. And this is that unlearning, getting over that is really difficult, and I get it. I really get it. And and as a result of that, lots of people make really bad decisions, either not to treat somebody or to stop their treatment because they are afraid of the bite change. And it reminds me of Almeida's 2006 Don, I think, was it? So where she talked about the fact that the problem is often created when the dentist's concern for the occlusal change is far greater than the patient's desire or concept of the problem and the patient's desire to continue therapy. When we look at all of the malocclusions that exist in the world and how they continue to do well, making a bite change very rarely affects their aesthetics or affects their function. More importantly, my biggest concern here is when we introduce this to patients. And when we introduce this to patients, we'll often tell them, now, your bite can change, but we really want you not to have we really want to keep this bite from changing. It's really important. So I'm going to give you this AM aligner. And I want you every morning to put this AM aligner in, and I want you to squeeze your teeth together in it until you can take it out and you can bring your teeth together perfectly. I am a firm believer, I have no evidence of the statement I'm about to make. I am a firm believer that there is more joint pain caused by trying to force the joint back with an AM aligner than there is with any other mechanism. More importantly, I am convinced of this. The suggestion to a patient that this will create a major problem is the worst thing you can do for a percentage of our patients. It can lead to occlusal dysesthesia, and that can drive a patient crazy because you've sent the message just how important that this is a major problem. And if that bite changes, they'll never be able to meet again. They'll never be able to kiss their wife. They'll never be able to walk down the street. That's the message we send them. And so, well, we may not say it. All right, I want you to come in now, right? We're going to check your bite. Tap, 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 tap. And then take out our loops and check the bite and look at all the dots real carefully. We said nothing, but we sent the message of how important their bite is. All right, that's interesting, Barry. How do you check the bite? John, would you open for me? Can you hear me? Open. Bite your back teeth together. Bite together. Yeah, looks good. Okay, that's my bite check. That's my bite check. That's it. That's it. No more than that. No more than that. Dental changes do not need to be prevented. Our goal is to minimize those changes and get the maximum treatment. Our goal is to have our patient breathing better at night, especially when it's critical. All right, next, John, I'm trying to get that. Thank you. How are we doing? Okay. 7, the bite registration technique is critical to success of appliance wear. All right, so a lot of people have been critical. First of all, there are several techniques that you can make, and we did an entire speakeasy session on this last time. So I'll just cover this very, very briefly and say it doesn't matter what you do. Until someone shows me a study that suggests that there's a better way to get to where you want to be, and I'm not going to make reference to the matrix today, because John's going to do is that we're doing that
this afternoon? Yeah. This afternoon we're going to be talking about the matrix. Yeah.
So we'll talk about that and what the possible advantages are, as well as what the possible problems are in terms of the model with the matrix. But the bite registration technique, the reality is, and I'll tell you a quick story with this because it's kind of interesting. I was back in 2007, 8, I believe it was. I was doing traveling the country for a year with SoundMed when we were introducing SoundMed to the country, and every other week I was in a different city and became the SoundMed representative. You know, needless to say, just for the record, when SoundMed hired me, the deal was that I could talk about other appliances. I was not just going to teach SoundMed, and that was all accepted. And so we spoke around the country, and I was teaching the use of one of the techniques with a George gauge. Now, a lot of people ask, if you take a George gauge bite, is that a good bite? And the answer is George gauge is not a bite technique. It's an instrument that we use in a technique. So to ask about a George gauge bite as though my George gauge bite is going to be the same as your George gauge bite is crazy. That makes no sense. So, but and at that time, LVI was doing had gone to SomnoMed and say, we need more tongue space. We need to create a lingualess SomnoMed. And much against my preferences, they went ahead and created that appliance for them. And then I got contacted by LVI. They wanted to do a study, and their contention was that the best bite registration would be a neuromuscular. You can't make this up. A neuromuscular bite. They were going to tens all the musculature to relax them. There's been no definition of relaxation, but they used resting EMGs, which has not been shown to be related to any pain or dysfunction. But nevertheless, they were going to tend all the muscles and take a neuromuscular bite, and they wanted me to take a George gauge bite, and then we were going to take, try to have equal samples, so to speak, and though two different institutions, so it's going to be the same patients, and we're going to compare the results. So just think for a second before I answer. If you were me, what would your response have been? Would it have been, yeah, I'll do that? Would it have been, no, I won't do that? Okay. You got it? All right. Now, just like our yes and no questions, the answer is neither of the above. The answer was, surely, I'll be happy to do that. There's only one difference. What's that? I said, well, we'll take our George gauge, and then we'll titrate to maximum efficacy. And then once we titrate, we can then compare it to your neuromuscular bite. And the response is, well, wait a second, but That's not fair. I said, it's absolutely fair, because I'm not claiming that my George Gage original bite is where that patient's going to need to be. It's part of my technique. You're claiming it is. So let's compare your technique to mine. And so they rejected that decision, and they went ahead and did their own study on just AHI reduction with a neuromuscular bite. I'll only tell you that the study was never published. I wonder why. There is an issue with a sweet spot discussion that I want to have, and that is we have to keep this in mind. Every time we do an HST on a patient, there's a night-to-night 25% variability. We can't assume that there is a sweet spot, or that sweet spot is the same today as it is tomorrow. That's not the way physiology works. So I'll accept this. I'll accept a sweet range. I'd like to get in the middle of that range, so that no matter what happens, my patient is best controlled. Can we have the next slide, John? I've lost my mouse. Posterior support is required to reduce compressive forces on the temporomandibular joint. So we've all heard that. I assume that many of you are here have heard the concern about that. And I'll simply state this. Think about why we ask for, when we're doing equilibrations or we're putting in oral appliances to protect the joint at night, why we ask for immediate disclusion. And if I ask somebody, why do you want canine rise for immediate disclusion, or why do you want anterior contact and immediate disclusion, the answer always is the same, because people know this. It shuts down muscle. Okay. So why does it shut down muscle? Because we know when there is posterior contact, there's elevated muscle activity. That elevated muscle activity can be as much as elevation of 75% in the anterior temporalis and 50% in the masseter. We know that. We know that. So when we have that posterior contact, we actually have more forces in the system. When we look at an articulator and we think, well, there's no contact, and therefore that condyle is going to go up and back, is what we're taught. It's not true. The force vectors of the masseter from the zygoma to its origin, and from the anterior temporalis to the coronoid process, is anterior, brings it forward. Nothing brings that condyle up and back. In fact, the concept that most joint pain is a result of compression causing pain in that highly vascular, highly neural retrodiscal tissue is at least in question. This is why, when we go back to what I said before, usually this is the result of what? Of sprain or strain in the joint. How can it be the retrodiscal tissue when in general, what we're doing is bringing the condyle to the eminence or beyond?
And Barry, just to let me interject something here quickly. It's now 2 p.m. Barry just has a couple more points to go, so we're going to complete this. Whoever leaves the program as of now will be entitled to the CE credits. If you stick around for a few more minutes, you can hear the rest. And of course, the entire program will be posted on stdacademy.com in the next couple of days. So if you do have to leave because you've got somewhere to rush off to, you'll be able to catch Barry's final points going on. Okay, thanks, Barry.
We also have, we also have a couple of questions that came through the chat for Barry,
yeah.
a comment.
Points, yes, okay, perfect, yeah. Thank you. Thanks, Barry.
So we'll get to them. We'll get to 2 more points. Okay, the next slide. The next slide, John. Sorry.
Yeah.
Degenerative joint disease and internal arrangements are contraindications for oral appliance therapy. I find this absolutely fascinating. Hang with me. Does this remind you of the argument in restorative dentistry about where the condyle is supposed to be? And everyone's arguing over where the condyle is supposed to be. And the first question I ask is when, because it's certainly not in function, and it's certainly not, so in order to determine where the condyle is, what do restorative dentists do? They tend to bring their teeth together where it should never occur in the first place. And then they say, and if that disc is out of place, then you can't have centric relation, because centric relation requires a normal disc condyle fossa relationship. So now what do you do as a restorative dentist? And more importantly, how the hell do you know that? So it's such an academic argument that they make so real and practical that I often laugh and think that oftentimes our restorative dentists create many, many hoops for us to go through to make restorative dentistry and the concepts much more difficult than it is. And then we take that with us and we bring it to sleep medicine. Degenerative joint disease is an alteration, as you know, in the structure of the articular cartilage, the disc, the fibrocartilage of the fossa and the condyle, and of the fibrocartilage of the disc itself. And it creates that rough sound and oftentimes the grinding that we hear. And there are a lot of things that make this joint different than in other joints. It's glycomoarthroidal. It certainly has a hard endpoint. There are many things that make this joint different. No question. There are many things that make it like other joints. And one of the things like other joints is that the issue with degenerative joint disease is that weight bearing makes any progression of the disorder more rapid. That the real treatment for degenerative joint disease is elimination of weight bearing. Now, if you've got severe degenerative joint disease of your knee, your doctor doesn't tell you run only 2 miles a day. He says don't run. So we need to look and see when does this degenerative this weight bearing occur. And the good news is that it only occurs at night in the presence of parafunction, which is one of the reasons that we like to avoid the stresses on the joint during the parafunctional event. And so with the patients with degenerative joint disease is a clear indication, in my humble opinion, for an anterior midpoint stop to avoid the strain. I know that there's a theory there that suggests that there's increased joint forces, but the literature suggests otherwise with anterior midpoint stops. What about an anterior disc displacement of some sort? In other words, the disc is tethered by the lateral collateral ligament on the outside, the medial collateral ligament, the pterygoid, the inferior lateral pterygoid, and much of the superior lateral pterygoid anteriorly, and the rest of the discal lamina. So it's which was at one time entitled posterior ligament. So if there is some alteration, some compromise in this tethering, the disc position becomes wobbly or come out of place. Bringing the mandible forward doesn't aggravate this condition at all. So because you've got an anterior disc displacement, the only reason you would consider that a contraindication for sleep therapy is because there's a lack of understanding of the joint. It scares us. We don't want to make it worse. And even though we won't, it scares us that we will. So, and here's the thing, you don't have to know how to treat an anterior disc displacement. And we can talk at length about treatment and how that gets done. But the reality is that if we can decrease the forces, we can take the destructive forces of parafunction, turn them into adaptive forces, and decrease and alter the shape of that disc, maybe decrease the click. And no, the condyle is not going back, but you've actually helped your patient. The answer is, I've never, ever, John, seen a patient that I've done a comprehensive examination on, looked at the joint and said that joint contraindicates an oral appliance therapy. Never. Next. Last one. HSTs are inferior to PSGs for diagnosis of OSA. It's really interesting, and it calls for a lengthy discussion of HSTs that I will shorten here for the sake of time. There are a lot of reasons. There's a lot of information that we can get from a polysomnogram that we don't get from an HST. There are a lot of and there's a lot written in the literature that suggests when and how a polysomnogram needs to be incorporated. But when it comes to diagnosing obstructive disorders, that's not one of them. Right? Interestingly enough, there really is a problem with HSTs, according to all of the lists, across the board, at lower levels of apnea. So in the mild cases, the HSTs become less valid. No question about it. And so that raises a concern to some, because what if, you have a patient that really has an AHI of 4, and your instrument tells you it's an AHI of 7. That means that patient went from not needing treatment to needing treatment based on the validity of the test. And this is the essence of the point I tried to make you before. No, we can't just we need to treat people, not numbers. So we need to look at that patient, and maybe that patient with 4 needs to be treated, and maybe that patient with 7 doesn't. And the treatment wouldn't vary if it was 4 or 7. There's no magic line at 5. I am convinced that the Ment and his gang were drunk when they according to one of the books I read, they were at a bar when they decided they had to come up with a number, and they said, well, how about 5? There was no evidence in terms of its effect on the health of the human when they came up with that number. Some of the studies are better than others, no question. And one of the biggest factors that makes a study better than another, not only is it obviously its consistency, but its determination of true sleep time. You can't determine true sleep time simply with actigraphy. And many of the studies use actigraphy to determine sleep time. So there are advantages. And think about this when you talk about COVID-19. There are advantages to using the WatchPat now, because the WatchPat does actually use actual sleep time. And one of the other major advantages now for WatchPat is that the WatchPat 1 is disposable. And one of our major, you think about what Elaine and Callie are going to have to go through, and all those people who are giving out HSTs. Now, the changes that we need in order to protect the patient from patient to patient, and what changes need to be made, and how we have to show our patient how safe that instrument we're giving them and putting them on is. That gets eliminated with a disposable appliance, and is going to be preferred. I will tell you that I know obviously Joel and now Lenine is working for WatchPat, and I will tell you that they can't keep up with the supply, with the demand. They can't keep up with the demand. It's massive. So the critical area really becomes that our physicians fought HSTs tooth and nail, and now, of course, because now Medicare and other insurance companies won't pay for polysomnograms, suddenly HSTs are acceptable, and they can be used. I certainly believe wholeheartedly that they can be used by dentists, given to patients by dentists for purposes of titration. And in some cases, the rules are changing constantly, and your relationship with your docs. Some docs are asking the dentist to go ahead, give out the test, and let them diagnose from it. Whatever. There are no those. There's the wild west trying to figure out the best way to get patients good access to their care. But HST, or the concern about HST being a good diagnostic test, should not be one of them. So that does us. I am so unused to not seeing people. Are you? How many are still here? Do we still have people here?
Yeah, we've retained most of them through to the end here, Barry. Now, Elaine has some questions accumulated for you, so perhaps we can jump right on that because it's about 11 minutes after the hour right now. So let's get right on to those questions.
I thought it would take longer. Yeah.
Yeah.
Okay. All right, Elaine, shoot. I can't hear you, Elaine.
Elaine, you're muted, sweetie. Oh, there you go.
I'm muting myself, yeah. There's just a little bit of a lag. I'm sorry. So
No
Dr. Scribani was the first one to actually reach out. He really needed to ask you a question, but he didn't write what question it was. So he just wanted to.
I see.
Miriam,
So I'm going to stop you for a second. So those are here. One of the things that make this point out that this temperament of the joint is different than other joints. And we get this, Steve, we get this all the time. I get so many times people will say to me, how can you possibly treat the joint? I mean, you're sleep docs. You didn't take an x-ray. Now the patient comes in pain. Should you now take an x-ray of that joint? How can you treat the joint without an x-ray? You wouldn't treat a tooth without an x-ray. Your doctor wouldn't treat a knee without an x-ray. Well, what we've learned is that the x-ray, the plain film, and even oftentimes the MRI rarely contributes significantly. There are red flags to tell us to take films, but rarely does it contribute significantly. Now, in my growing phases of treating temporandibular joint, along the line, I was asked to go to Boston. And I gave a lecture at Tufts through Bob Muir, and I got to meet one of my dearest friends, Steve Scribani. And Steve and I, at that point, didn't know each other very well. And we arranged for Steve to come to my office and spend a couple days because he was curious from my lecture what models, and I think he learned something from Bob Muir about my appliance therapy, what lectures what processes I was following. I remember the night before of going to bed, I turned to my wife and said, oh my God, Scribani's going to be in my office. I don't image these patients. I know he's written books on image. I mean, he's an expert in imaging, expert. And I'm thinking, I am in deep shit here. So the first patient comes in and has a complaint about some degenerative disease or whatever, low-grade pain or whatnot. I gave my diagnosis, I gave my treatment, and I'm thinking to myself, okay, we're going to go back to the office, we're going to talk about it. Steve and I talked about it, and he was, thought the thought process was excellent and shared some thoughts with me. And I said, oh, didn't say anything. And then the next patient comes in, and then same thing with a pain thing, and now the patient's got a click and whatnot, and I give my treatment plan, and again, I don't give any imaging recommendations, and I walk back, and I go, oh, no, he's going to hammer me, and Steve says nothing. He says, we have concept, we made some suggestions, we talked about the guy, was happy with what I was doing. Now the next patient comes in, it's a young patient with a sudden closed lock. And I'm thinking to myself, boy, would I like to know where that disc is because I could do a mandibular mobilization. So I proudly suggest, yeah, we're going to go ahead and I want you to go and get an emergency MRI and I'll see you tomorrow. And we go back and Steve looks at me sitting there and says, what the hell was that for? What do you need the image for? You know exactly what's wrong. Just thought I'd share that. Next.
Okay. So we have Mariam Siddiqui asking if you can repeat the part about the liner because she didn't get it.
About the
morning
liner.
Morning liner.
Morning liner.
So just for those who, Miriam is a brilliant young lady doing pain management in Minneapolis, right? And I think in Minneapolis, and we met at a injection course that I gave in Temecula, Florida, California, and I was so impressed with so much of that whole group and with Miriam. And the answer, Miriam, is that the AM aligner, that concept that I'm going to force this jaw back. Why is the jaw out of position in the first place? And it can be several things. It can be one, muscular engrams, just from being forward all night. It can also be some increased effusion in the joint from being forward all night and possibly in the presence of parafunction. I don't know that. But so she can have some, or simply altered anatomy as a result of being forward. The thought that I got to take that patient back, and two things. Number one, I'm forcing the patient to bring your world back and squeeze in it. And second of all, what I'm doing to the patient's head, because now they have a goal to get that back. So if I'm going to use an aligner, I'm going to say, you can put this in. I want you to bite gently into it a couple of times, 2-3 times for 2 or 3 seconds, etc., without forcing. That's the way I want to use that. My preference, remember, when we put in appliances, we always tell patients, listen, sometimes there are some untoward effects, like any drug or any medication. Sometimes not that great things happen. One of the things that can happen is that we can have some tenderness in the joints or the muscles. Usually that's minuscule and can be easily resolved. Sometimes we have some minor bite changes. Usually that doesn't affect the aesthetics or the way you chew or function. Our goal is to minimize that. I'm done. I've now given the explanation. So now I'll tell my patient when I give them the appliance, what I want them to do is to keep chewing gum in their bathroom. And in the morning when they take their hot shower, take the chew and with hot water on your face, chew gum throughout the shower. And then when you get out, throw the gum out. And oftentimes, honestly, between that and 10 or 15 minutes of time, that resolves the bite thing. And even if it doesn't, at breakfast, they know the teeth don't come together when they chew anyway, so they'll notice a little change. Their body adapts so quickly, and usually that comes back. So, interestingly enough, the bite changes that we saw, John, early in our career with oral appliance therapy really seem, ask me why there's so much less. Why are they so much less, Barry? Answer,
why are there so much less, Barry?
I don't know. But they really are. And I honestly do believe that they are less with anterior midpoint stops because there's less potential forces on the teeth. Great question, Miriam. Thank you.
Now, that's completely anecdotal. That's completely anecdotal. Just thought I'd mention that.
Yes. Okay. Yes.
So next, we have a comment from John Boozies. I hope that I'm pronouncing it right. He has a comment saying that he worked alongside our local sleep physician with a patient that had an AHI of 107, failed CPAP, and as a matter of fact, said that he would rather die than wear it. He placed a cap, and although they only reduced his AHI to 29, when all things were considered, he labeled the therapy successful, and so did the patient.
There you go.
Yeah.
And yet, if you did it with an oral appliance, some physician would have said you failed. It's the way it is. Yeah.
Yeah.
Anybody else?
Next, we have a question by Greg Vogel. Hi, Greg. What are the key pieces of literature and EBR everyone in DSM should all be familiar with?
That's really a great question. And I will tell you, Greg, what I will do. I'll pick 20. It'll be hard. I'll pick 20. I certainly all of the work about disease means disease alleviation. I think it is critical. I think some of the work about oral appliance changes Almeida's work is really good. Obviously, I'm a fan of anterior midpoint stops, so I would consider the work of Hattori and Hasegawa really critical. So there's the work that Guam, for example, talking about AHI not being essential or Epworth being misused. There's some really good work now on AHI and some movement toward ODI and certainly trying to get all that's really important. Having said that, the number one thing I would want to teach dentists is to stop looking for an answer and to stop thinking like dentists. in terms of perfection or precision. And to understand in reality, think of the number of patients of mine that had some bite changes, and I know that if they weren't prepared and they weren't educated, when the general dentist told them about how horrible their bite changes were, how difficult that would have been situation been for me, and because my patient was educated and had a relationship with me and was anticipating that response, I didn't have the war that I would have had. So if I could teach one course, if I could teach one course that I think would be important, yeah, I would include some basic literature to beat some of those myths, and I'll put 10 or 20 of them together for you. I will do that, Don, and I will get that to you. But at the same time, just for your own, just to read and to give to your docs. But at the same time, if I could teach one course, it would be in patient management. Patient management really, it's not lip service. This isn't. I was going to use somebody's name. That's not fair. This isn't BS. Patient management is so much more important than appliance therapy. Anything else, Elaine?
Yes. We have a question. Oh, Mariam Siddiqui says, thank you, got it. And the next is from Mark Levy. Could there be less bite changing because we now have options to ball class retention?
You know, a lot. That's really interesting. It may be that a lot of people claim, including Alan Lowe and others. A lot of people claim that a lot of those bite changes, Mark, were a result of the ball class, and I've never seen anything to suggest that was or wasn't the case. But I don't think the real issue is that the open contact, which you would expect from that. I don't. To me, the bite changes are these bodily mandibular changes that we're seeing. Yes, at one point we were getting a lot of mandibular flaring. You know that, Mark. That seems to have stopped. At one point we were getting one of the things that I find so fascinating is this assumption that if we don't wrap the second molar, we're going to get distalization in open contacts. A lot of my appliances don't even cover the second molar, and a lot of them only went to the first buy. And no, we didn't get extrusion, which was interesting, super eruption, and no, we didn't get open contacts. So that assumption that I'm going to stabilize everything. Think about it. Think about the number of ortho-retentive appliances that orthodontists put in post-ortho. And then they wind up with open bite, or they wind up with occlusal changes in the posterior. See it all the time. So this concept that I'm going to keep everything stable and how could it possibly move if I've got it tight, that doesn't seem to work. So it may be that may have been a contributing factor. I don't know that.
Sorry. Oh my goodness. We actually had a question from Gurun Sidhu, and he had left. He was asking, what is a good screening tool? Okay.
So, I mean, there's lots of them out there, and my favorite is the adjusted neck circumference, but the negative is that you have to take a tape measure and go to somebody's neck with it. A lot of people use the stop bang, and that's a really good screening tool, I would think. John, can you think of anything else, any others that you use?
I think the stop bang is probably as good as any, and it's nice and simple that any auxiliary can very quickly administer that. Yeah, I know you like the adjusted neck circumference one, which is an alternative, and they're all pretty well much the same. Is that they're going to give you some insight. I don't use either of those.
The key is that I would rather have a false negative. A false positive, a false positive and a false negative. I'd rather include more. So when we did the adjusted neck circumference, one of the things we noted was that there were patients with AFib that weren't fitting in and were getting past the adjusted neck circumference.
Yeah.
So we actually it added AFib and diabetes to the adjusted neck circumference, which by definition actually took a validated study and made it unvalidated. But I did it on purpose to include more, so I didn't miss an AFib patient.
Yeah.
Because the strong relationship that we found between AFib and sleep disorders is massive. Yeah. Elaine, is that it?
That's it.
Well,
Good job.
it's 2:26. Thank you very much, Barry. That was great. And this recording of this is going to be located on our STD Academy website in the next couple days. I'd just like to thank you, Barry, for presenting. Thanks everybody that joined us. And want to take the opportunity to send out a heartfelt thank you to all the medical personnel on the front lines. My heart really goes out to all of them, and I'm sure that you all feel the same way. And I want to take a moment to acknowledge all their efforts while we're basically doing our part, isolating ourselves and trying to sort of dampen this curve. They're on the front lines dealing with this nonsense, and I really feel for them, and I appreciate their contribution. Now, we're going to be winding this down now because in about a half an hour, we're back on with Dental Sleep Medicine Speak Easy, and we're going to be talking about predicting oral appliance success. Is there anything you want to add, Barry, before we leave? Yes.
There's one more question that just came in. From Jim, Jim Rodriguez, asking your good advice to avoid the medical dental exactitude trap. I'm not really sure. It's a comment. Just your good advice to avoid the medical dental exactitude trap.
Okay. Thank you. I don't think that's a question, right?
No, that's it.
Okay.
Thank you, Jim.
Everyone, for joining us. See you at the next Corona webinar. Thank you, Barry. And hopefully some of you can join us this afternoon in about a half an hour. Ciao, everyone.
Thank you, guys.